on some ways, I get better nights on the tandem control IQ in the sense that there's less tinkering. And so when people don't tinker, sometimes it's just flatter. So it depends on the patient. And if people eat late at night, it's really never as good as if people kind of eat earlier.
Yeah, it's a loop works great if you're an empty stomach sleeper, that's for sure.
So do all these systems.
Yeah.
Okay, I'm going to jump on. All right. Hello, everybody. Welcome to SoCal Loopers. Thank you for joining us today. Very cool event. We get to hear from Dr. Ann Peters from the USC Westside Center for Diabetes in Beverly Hills. As I normally do, because we are talking about the DIY loop, we will give the disclaimer that the Loop app is a do-it-yourself closed loop algorithm and user interface developed through the work of community volunteers. While it may seem obvious, please consult with your healthcare professional regarding your diabetes management. Importantly, this project is highly experimental and is not FDA approved for therapy, and therefore you take full responsibility for building and running this system, and you do so at your own risk. I would like to introduce you to Dr. Peters, and I could talk to the whole hour and explain her entire background because she is that amazing and wonderful. And when I first met her in January, I had heard she was amazing and wonderful and that I would fall in love with her. And I said, yeah, probably, maybe. I understand why everyone tells me that now. She is the world's leading diabetes clinicians and clinical researcher. She's an influential advocate and policy advisor for new diabetes treatment guidelines and increased access to care. She's dedicated to bringing cutting-edge diabetes care to all walks of life, including the underserved lower literacy population, which is also very interesting if you want to ask her some questions about that. She has been a principal investigator in multiple clinical trials, incurring, this may be old, I don't know, you can tell me, Anne, including 2 current grants supported by NIH and several foundation grants. She serves as special consultant to the US FDA on the development of devices for diabetes treatment. She is a sought after speaker. I've been seeking her out and she has always stepped up for us. She hosted SoCal Loopers in February, when we only had about 75 members. And she was the first healthcare professional who welcomed us to actually let us talk and meet and was happy to participate. She is considered a thought leader who plays a central role in developing national guidelines for diabetes care worldwide. She's authored more than 200 articles, reviews, and abstracts, and written 3 books. It could be more by now. She supports all loops and is knowledgeable on all loops. And she manages them in her practice. She has cared for world-class athletes and shares her knowledge about diabetes coupled with exercise. I think I've said enough. And thank you so much for being here. We know you're wise. We love it. And welcome.
Well, thanks for having me. So I'm not going to say too much that's formal because most of all, I just like to talk with you all. If you notice that my dog is to my side, she just had major surgery, so I'm keeping an eye on her to be sure she doesn't leap through the air and tear out all her stitches. But this is the deal. I was thinking about this, and you guys invented telemedicine, right? Because if you wonder how do people on Loop learn about Loop, it's all through telemedicine of a sort. It's actually telegroup medicine, or it's individual telemedicine, whatever it is, it's doing it over the internet, and it's doing it in ways that aren't sort of standard. And you're doing it and learning through your own collective experience. And it doesn't mean you have to be in a place. And I kind of think in a way, you guys are the forerunners of all that's happening. But I have to tell you a couple of things. I'll tell you my best story, and this has nothing to do with Loop, but you have to hear it anyway, is that, you know, I work in underserved East Los Angeles where COVID is awful. So I work in the epicenter of COVID for the county, and all of my West Side patients who are higher SES, higher education levels, every single one of you all who is, you know, able to use something like Loop or able to come see me in Westside practice has done great. Not one of my patients has been in the hospital. Not one of my patients has died. And I've had lots of patients now with type 1 diabetes get COVID, and they're all doing fine. And I actually noticed that the CDC, on their initial concerns about COVID, listed diabetes as a major risk factor for COVID. And just a little while ago, they split it out. And now under major risk factors for doing badly with COVID, it's type 2 diabetes. And they took type 1 diabetes and put under might be a risk factor for COVID. So to me, that's where it should be, because if you look at the data that we have, if you have a good A1C and you get COVID and you have type 1, your risk isn't increased. So I can tell you, my type 1s who've been getting it do just fine. Same with my type 2s on the West Side. But my East LA patients are dying, and they're dying horrible deaths. And part of why it's horrible, understandably, is because you can't have visitors. And so, I mean, I have never in my entire life seen worse healthcare disparities than I see now. And I've spent my entire life working in, poorer parts of town and in wealthier parts of town. What's happening to our neighbors just across the way is just awful. So we've been trying to make it better for them. And one of the first things that the County of Los Angeles decided to do, and this may shock you, is that they decided that instead of making people come physically once a month to pick up their insulin, that they would give them insulin for 3 months and they would ship it to their house. Now, this is revolutionary in the County of Los Angeles because it really decreased our rates of hospitalization for DKA. Shocking that if you actually give people with type 1 diabetes insulin, you can save their lives. To me, that was amazing. And now we can write prescriptions for a year as opposed to just small amounts. So we've stepped up that way and really helped type 1s. Then I got a grant from the Helmsley Charitable Trust and Insulin for Life, which basically gave me Freestyle Libres to just give to people for free. And so we started creating telemedicine in East LA, and we do, a lot of them can't even do video stuff because they don't have computers or smartphones. So we do telemedicine just on the telephone. And so it's unbelievable because suddenly I'm having all these patients who are using CGM, which for them is huge because these are people who have A1Cs between 12 and 14%. So we got referred, and this is what I'm going to end with my speech about helping the underserved. We got referred a young woman who's in her 20s, and this was in the beginning of the pandemic, and her A1C was above 14, so we couldn't measure it, and she was doing really badly just in life. And for reasons unclear to me, we decided that we could put her on a CGM and on a pump and on Control-IQ, because that's what we could do. And we could do this all on the telephone. And so we took somebody, using our diabetes educators who speak fluent Spanish, who are wonderful. We took somebody from 0 and put her on the Control-IQ system. In 2 months, her A1C went from above 14 to 7.7, and she loves Control-IQ. And so the possibilities of what we can do as a community to help our neighbors and everybody else my mind has expanded, but I still see this horrible, horrible risk, and it's not getting better. So we've looked at the rates in LA County. I look at them every day, and it's still, the health disparity is huge. And it's we don't even understand why it's so bad for the underserved with COVID, although it could be because of where they live and they get a higher dose, or I don't know, we just don't know. But anyway, I'm full of good stories, but I'm also pondering, what I've seen in terms of people becoming homeless and having food insecurity and everything else. So there's a lot we all, like I said, have to do. Beyond Type 1, which some of you probably know of, has created this website, which is called getinsulin.org. And it was a consortium of ADH, ADRS, everybody, and then the pharmaceutical companies, all of them put in money. And what it does is it matches up people not only with insulin that they can afford, but it also matches them up with free clinics. And you put it in by zip code and it works all over the country. And we have to get the word out to our fellow people who care about people with diabetes that this exists, because, you know, to see any deaths because people can't get insulin, to me is just horrible. But I'm sorry I had to go on my little political sidetrack about the fact that people with type 1 diabetes just need insulin and they need healthcare. And I don't really care what your politics are. We have to get people with type 1 diabetes the care they need. And, you know, Loop fits in this in spades for me because Loop is wonderful. I love Loop because my patients love Loop. I only love what my patients love, by the way. And it's really great. And I thought maybe that within the other systems came out, like the tandem control IQ system has really worked for a lot of my patients. And there's certainly patients who don't want to do the futziness of Loop, but, or do it yourself system of any sort. But, you know, as I've gotten to know the tandem control IQ system, I'm really well aware of its limits. And I know that you all, through a DIY system, can do a whole lot more. It's like you're always going to be ahead of what's commercially available, always, because of the flexibility you guys have. And all the things that I keep telling the companies that I want, you guys can already do because you can create it. And, you know, there's geniuses out there amongst you. And I'm so impressed. So when I got my first patient who was on the bolus branch, first of all, I thought that Tidepool had become psychotic because it listed, like, you know, 50 different bolus doses in every hour. I'm like, what the heck is this? And it's really been great to see patients doing what seems to me smarter than just changing the basal, but giving those teeny tiny bolus doses all the time. And it really works. I think whoever figured that out was just spectacular, right? Because of how it is able to do what the body does, which is to give tiny little bursts of insulin. So it makes a lot of sense to me to use that particular branch of Loop and to see the benefits. And again, there's no one size fits all to any of this, but the DIY systems are just always going to be ahead of everything because you can be, you know, whoever it is out there in the ether land that makes all the algorithms is just unbelievable. No, I know it's more than one person, but whatever you guys have is spectacular. So I've ended up just loving, you know, learning more about Loop, learning more about the bolus branch, learning, you know, how I can help adjust it to what my patients need. And, you know, sitting here in front of my computer, which is what I do all day long, the only thing I don't like is that it's harder for me. I wish that the settings came into Tidepool because it really like slightly annoys me that I have to get all those screenshots. And I know you guys use Night Scout, but my brain doesn't work with Night Scout. So I get like a screenshot of the iPhone and all the settings to then adjust, but that's okay. It's a small price to pay for this.
All right, I have questions already. I'm going to roll you back to coronavirus and those issues because you've been very much out there and we can get that kind of out of the way. A couple of questions. Someone had asked me earlier in the week, has treatment progressed since March, and for particularly, are they safe for type 1 diabetics? And is there any impact on kidneys for compromised type 1s on any of these drugs? She mentioned remdesivir.
Well, so this is the deal. I think we've gotten better at treating COVID because we know, let's see, how do I say this? We know how to approach the patient better. And the two treatments that work the best are early anticoagulation with heparin, which we've used forever and doesn't hurt you, and high-dose dexamethasone, which makes your blood sugars go through the roof but doesn't hurt you long-term. Remdesivir probably doesn't work. Convalescent plasma probably doesn't work. And whether or not the monoclonal antibodies work is unclear. So we basically don't have a treatment for COVID. And we would like to think that of the millions of drugs that are in development, there's going to be benefit, but the Lilly monoclonal trial antibody, the Lilly trial on monoclonal antibodies just got halted for safety. So we're going to have to be really, really, really careful in anybody using brand new drugs to treat COVID. And I get it if you're about to die from COVID, that you may want compassionate use for something that nobody's tested before. But for most people who get mild to moderate COVID, you don't need treatment at all. You're just going to be fine. I had COVID. I got it in the very beginning of the pandemic. And, you know, it's not fun. You're kind of sick for a month, but it doesn't like ruin, it didn't ruin me. I thought, I don't know. It's like, I didn't know I had it when I had it. And you just don't feel right. It's losing your sense of taste and smell. That's really weird. because food tastes like sawdust. It's not that it doesn't taste, it's that you can't eat it because it tastes like nothing, but nothing is a taste. I hate to tell you this, but anyway, the point is most people, most of you all aren't going to get bad sick, but the things that are really a risk factor are age, and being male, unfortunately, it seems to be a risk factor. And then, being overweight is a risk factor, but type 1 diabetes itself, that's well controlled in particular, isn't. But anyway, we don't have very much in terms of treatment, but I would say that people are doing better because we anticoagulate people earlier. So if they're in the hospital, so we don't get that coagulopathy. And then we give steroids if people start getting that cytokine storm. We don't even think it's cytokines anymore. We think it's bradykinin, but whatever that weird storm thing is that kills you, which is a hyper response of your immune system, that's when we give you steroids. But, so many more people are surviving it. But part of the reason many more people are surviving it is because, as I mentioned, age is a really bad risk factor. And after March, most older people decided to be in a bubble and not get it, which is a very good idea. And so we're not seeing the death rate because older people got smart. Younger people out there remain not smart. And so I'm seeing my 20 and 30-year-olds getting COVID because people in their, the younger people want to go out and socialize and party and have a nice time, and their prognosis for COVID is really good. So most people don't need treatment.
I read something that COVID is somehow loosely related to blood type. Not that you can do anything about that, but are you aware of that?
They disprove that.
Okay, great.
But I was the worst blood type, and I don't seem to be dead. So I'm just pointing this out. But we don't. So this is the thing. This is going to last a really long time. We don't have a treatment, and we have to have a treatment. And before we can all go out, and I can because I had it and I didn't die. But you know what I mean? It's we have to have a treatment. We have to have a reasonable vaccine that's safe, and it has to be tested, and we have to know that it's safe. And so everything, when they say, oh yes, we have a vaccine, I'm not so sure that I'm going to trust the first one that comes out. And I don't even know, I've got to see the data. But even the best vaccine is only going to be 75% effective. So people who are in high risk categories aren't going to be able to go out still. And, you're not going to want to go into a small closed indoor box. That's just not good for you because you'll get COVID. This stuff spreads a lot. But backward, the best thing is wear a mask. If you wear a mask, hand sanitize and socially distance and stay outside, you won't get it. You don't have to get COVID. I mean, if you're a healthcare worker and two people with COVID sit in front of you and breathe heavily on you for 45 minutes, you might get COVID. But short of that, you're not going to get COVID if you don't. I mean, if you protect yourself, you won't get it. So that's, that to me is optimism. And we just all have to figure that we'll just wear masks and be smart. I don't know. And I still wear a mask when I go out because what if I could get it again? And I didn't give it to anybody else. I didn't give it to my 92-year-old father. I didn't give it to anybody else. And when you get COVID, you have to make sure you don't give it to somebody who could die from it. I mean, that's, how bad would I feel if I'd given it to anybody else? So unlike certain people in government, I really believe in protecting others from me.
Thank you for that.
Right.
Just one more COVID question really is, if you end up in the hospital, we talked early on about having your go bag ready, having all your medical records together. Some people have done that, other people have been slower at it. But the question is about dealing with a hospitalist if you can't have your advocate in. Is there a good advice on how to advocate for ourselves if we're sick in the hospital and we can't have an advocate with us?
Well, the problem with COVID and the reason it's so freaky for medical workers is that we can't go in and hold your hand. And if you're bad sick with COVID, the doctors don't want to stay in your room very long because they don't want to get sick with COVID. So it's really freaky that way. So what you want is to have the professional staff willing to tape your CGM receiver to the door and use your CGM to look at so they can help monitor you. I would say that you should make sure you have a receiver for your CGM. But if you look at the inpatient protocols now, they all use the receiver and they stick it outside the door in a baggie. which makes monitoring diabetes much easier. So I would say make sure you bring your own stuff, but also think about how you're going to let other people monitor your sugars. And I just saw in a diabetes article on Diabetes Therapeutics and Technology, there's a review article about diabetes in the hospital. And in it is a form that patients sign that say that they basically are assuming risk for using their hybrid closed loop systems and sensors in the hospital. And that form seems to me like something hospitals should have for you all, but you might want to bring that form printed out and say, this is what I will agree to if you let me use my pieces. So, and you know, a lot of us are advocating that unless you're unconscious or something, you should be able to use your own systems. But, you know, there has to be some liability waiver, but this is an actual like suggested liability waiver. So
Well,
I would look that up.
I'll find out. A couple of us have written on one that we put out as well. Just, it's better than nothing. It says, here's what I do, here's what I manage, here's what I need, here's what my doses are. And I know how to manage this unless I'm not conscious.
Right, which is what exactly you need. So
Mhm.
that to me, if you would send that to me too, that would be great. But
Yep.
that's what I want every patient to have, to bring in and say, look, this is, you know, but you're not going to be feeling that great if you're this sick. But I'm just pointing it out. It needs to be part of your medical record in a way, like it just needs to be.
Well, that's why we're encouraging, get your go bag ready. Have your backup supplies in a backpack ready to go out the door. And that way, when you don't feel well, you don't have to organize it. It should be organized. Maybe every 6 months you review it. It's hard to do then, to suggest people do it, but if it's ready to go, it's ready to go. And particularly since we live in earthquake country, you never know when there's an emergency. So it's not a bad idea overall.
No, I think it's a great idea. I think we should all do it. I mean, and it always gets forgotten until the next bad thing. But particularly if you have devices with type 1, it's all about advocacy of, you know, letting people trust that you know how to do this, because most physicians don't have a clue. Type 1 diabetes management in the hospital is terrible. So you guys have to really advocate for that, the ability to manage it. But again, I'm telling you, most of you are going to be so fine. The vast majority of you all are going to be fine, even if you get COVID, which is something that's, you know, makes me happy. I'm telling you, I've had people who are, you know, 85 years old, they have type 2 diabetes, cancer, kidney disease, heart disease, strokes. They all do fine. I don't know what it is. My patients just do fine with COVID. Don't wreck it. But I'm telling you, I know COVID's really bad, and I see people dying all the time in East LA, but not my Westside patients. I mean, I think that it's, I don't know, my Westside patients are amazing.
Well, it could be partly you, but we'll let that one go.
I think it's the patients, but I think that people who are proactive about their health, I mean, I get part of it's just luck and bad luck, but I also think that I just think that we have more control and more access. And I think that makes a huge difference. And you have access if you get sick, just a little. All my patients let me know the first time their COVID test is positive, and then I hold their hand. So, you know, it's important to just feel like you can connect.
Mhm. I'm going to bring you into some looping questions. This is an unusual group. We have about 1,200 members worldwide, and what I've noticed is they are a very proactive, very engaged group of people. They're willing to work into uncomfortableness even to get better results, and they want information. So the question has been coming up lately about time and range, and what is a reasonable time and range, and is there a concern of too much time and range against too much insulin, or what is your recommendation for time and range?
Well, I've never ever heard of the problem of too much time and range. I've certainly had the problem of too low an A1C because of hypos. But the time and range of it depends on how you define your time and range. My loopers are sneaky and they make their time and ranges different, but time and range is defined by Rich Bergenstahl. And it's defined as the time spent between 70 and 180 in a 2-week period. And it's defined as if your time and range is 70% or more, that then means it's equivalent to an A1C of 7% or less. So at 70%, it's an A1C of 7. Now, that doesn't necessarily always correlate, but I'm just pointing out that's the general rule. And because the DCCT data, which is the best data we'll ever have, because I'll never do another study like that, showed that an A1C of 7 obviously was incredibly beneficial compared to 1 of 9, that's kind of where people want to be. But and the other thing is, obviously, most people aren't even that good in this country. The average A1C in adults is 7.9. So I don't know about too low, because I have people who are in the 90s, 98% time and range. I have people who have an amazing amount of time and range, and they don't seem to me to be over-insulinized. I calculate the weight-based insulin dose on people. I look at all this, right? And every time I see somebody, I track their total daily dose and I look at weight change. So somebody's not gaining weight. And a lot of my patients don't gain weight or even lose weight, right? Because they're no longer going to eat for the lows. But how much your time in range is a really good thing, because it means you're not high or low. So, if you look at somebody without diabetes, as time in range is always, it's 99 or 100%. So I don't think it's bad. I don't think you can be too much time in range, as long as the parameters, you're not gaining weight and you haven't suddenly gone from 40 units to 80 units, but you're not going to do that. But again, I chart that. I was really worried in the beginning of hybrid closed loop technology to begin with, was that people would gain weight, but they don't. So I think they're doing better because of less lows, but I definitely don't think you can get too good. I do urge you not to compare, because each one of you is different. And each one of you has to have your own goals. And everybody's always getting all upset in my world. Oh, I'm not this. It's like, I don't care. I don't care. I don't care. I want to know you, the individual human. What is your goal and how can we get you there and what's right for you? And I really do have some people who can't get to a time and range even of 70% because it just, whatever it is that their challenges are, they can't do that. That's okay. I need people to be as good as they can be. And then we work with that, but don't compare. You guys love to compare. Do not compare.
The people that are proactive are sometimes just a tad competitive.
Yeah,
and they see the goal and they think they can achieve.
But the goal is to prevent complications. The goal isn't a number. And the goal, I believe it or not, I really truly have people who've had A1Cs of 9 or 10 who've never had a complication. And the thing is that there's such a genetic or an inherited predisposition to complications, so that not everybody's the same. And probably someday we'll do a blood test and we'll say, you're at high risk for complications. You need an A1C, time in range of 99%. I want everyone to have a good time in range, don't get me wrong. But we'll probably someday be able to separate people who more desperately need a better time in range than others. But everybody should do the best they can. But somebody who's lived with this for 50 years who has no complications is doing great. Maybe their time in range could be a little bit different than someone else's. I don't know, but all I'm telling you is that I individualize this. I don't want anyone to feel defeated, because everybody who does this is a winner. It's just harder for some people than others. So anyway, I get cross when I see too many people feeling too bad about themselves because they compare themselves. So I see the best, I see the worst. I don't judge. Don't judge yourself.
As we see people coming on to DIY loop and really any loop are getting possibly under better control. And Glenn had asked, do people with higher A1Cs need to be brought into control slowly? That used to be the concern. Is it still the concern?
Oh, yes. So I see it all the time. If people get better too fast, their retinopathy, they just explodes. It's really bad because your body is used to whatever the glucose levels are. And it's something that people aren't aware of. But I actually tell people if they've gotten too much better too fast to not be freaked out if they go to the eye doctor and they have a lot of retinopathy. It goes away, but retinopathy will get much, much worse if you come down too fast. But so I step people down. And that's actually one of the nice things about loop is I have, examples if we go, they're 300 or 400 and I get them down to 250 and then to 200 and then to 180. We keep walking down and it works. I like this going slower, but too fast really can hurt transiently your eyes, but they do get better.
Okay. Interesting question from Ashley. She's used DIY loop, she's used Control IQ, and she seems to be always adjusting settings and spending more brain power than she'd like to get a good time in range. And she mentioned surfing. Any thoughts on getting to settings and being able to coast for a bit, or is it always going to be adjusting?
Well, I don't know the answer to that because I've seen every variety of that. My goal is to make it easier to have type 1 diabetes, as is all of yours. And some people, it is easier more readily. All of it depends, by the way. A lot is how regimented one's lifestyle is. And if you want to have variety in your life, it makes it harder. But there's all sorts of components that go into that. But I think I spend a lot of time with patients setting expectations because I don't want people to spend too much time fretting over the settings because the settings aren't going to fix it necessarily because it has a lot to do with behaviors. So it has to do with how much in advance do you give the insulin and are you remembering to set the exercise mode or, there's an interface that has to happen, but the settings themselves, I don't know. I don't think people need to fuss with them too terribly much once they've got the system set up. And so most of my patients, I actually look more at behaviors than settings, but we change settings as much as is needed. But I tend to look at things like when you're not eating or people go on low carb diets, whatever, and then you see this amazing flatness. So you know that the settings are inherently right. It's just that when you change it and add in carbs and differing carbs, whatever, that changes how one has to use the settings. So it's that's why I like the bolus branch because I think it does more. But most of my patients don't need to futz with the settings all the time. We kind of futz with them in the beginning and then we can kind of do okay, except for adolescents. Adolescents are changing all the time, so those require change. But I think part of it's just accepting the limits to type 1 diabetes and no, we aren't at a cure, obviously. And this isn't, you think of how many different settings one has in a lifetime, right? How many different ways and, places you've been in a day. And, to think that a system can adjust for all of that is not possible. So you've got to say, does it adjust enough? And the answer, if it's, a decent time in range, that's probably good enough. I mean, that's the whole point. That's the perfection is the enemy of this. So
along those lines, Laura just asked, will autobolus help my 14-year-old with his time in range? And you just said it. It's puberty, it's diet, it's teenage diet.
My adolescents, they're so sweet, but it's so hard. It's so hard to be an adolescent. I know we got to remember back, for me, it's a long time ago, but there's nothing about adolescence that sticks, right? It's always changing. And so I just have the sweetest young woman who, is just like desperate because her settings aren't right for when she's having, or the week before her period, and she wants to adjust it right. And it makes her just crazy. And she's tinkering with the settings. And it's like, sweetheart, let's just calm down. Let's figure out a pattern that you can use during the week before you start your cycle. Let's figure out some sort of way through this. But, she's being so hard on herself, but it's all puberty and things. And should I go on the pill? And, oh, look, they're boys. And, I don't know, there are all sorts of things. So adolescence is the hardest. But I'm telling you, my looping adolescents have measured A1Cs, if you want that as a metric, of less than 7. And adolescence is the hardest time of all to have type 1 diabetes. A1Cs in adolescents are sky high. So I know my loopers do great, the adolescent loopers I have, but they're a rare subset because they're the people who are willing to work with somebody. Their parents maybe, but they're willing to do it. So I think it's amazing. So again, 14 is a tough age, but whatever works. I just don't know. I have actually a couple of adolescents with the bolus branch, but anyway, I can't give individual advice, but I can tell you that whatever works, but 14 is tough. 14, 15, it's all tough. Your prefrontal cortex is not myelinated until you're 25 if you're a woman and 26 if you're a guy. So for a huge long period of time, your brain still isn't quite with the program. So I'm just pointing this out. And then it starts to fall after 26, and we all get demented on some level. Our brain cells are dying off. It sucks.
That makes perfect sense and it's a little scary. We've had a question that's been asked twice, so I will bring this to you about back to time and range and micromanaging. If we are 80% in range, is there more advantage for lower risk of complications at a higher time and range?
So nobody knows. Again, yeah. I'm telling you, there are people who are more or less risk for complications. And, after you've had type 1 for 20 years, if you don't have any complications, it's actually, and even if your control wasn't great, particularly if your control wasn't great and you've had it for 20 some odd years, your risk of complications starts going down. So you don't have to have such a tight level of control. Over time, you know yourself if your body's gonna have a bad reaction. So we don't have long-term data that looks at time and range, right? We only have A1C data, period. That's all you're ever gonna have. And so you have to tie time and range back. But an 80% time and range in my book is spectacular. That's gonna be an A1C in the 6s, and you don't need to be better than that. You really don't, from everything we know about complications. I'm happy with anybody who's above 70 because that's 7%, and the complication rate in the DCCT goes so down at 7%. So, I'm telling you, 80% is great. Don't because you don't want diabetes to make your life miserable, and you don't want to have to fret over this so much.
Yeah, there's a quality of life issue here of the anxiety of getting it tighter and tighter. So the question about, this is a new one, I haven't seen this question. Starting a loop postpartum 7 months, she's on MDI, and hormones seem to change the insulin sensitivity so much. Have you seen loop in new moms?
Well, I've seen loop all the way through pregnancies. So I've not felt that I felt that it adjusted fine. So I haven't seen anybody, I'm trying to think. See, my problem is that my women who are new moms with type 1 had it during pregnancy. So they did their tightest control during pregnancy because their A1Cs were in the 5s. So then they come out of pregnancy on whatever system they're on, and they're still doing well. But I think the system works through all those hormonal shifts. I think it's actually better for that. If there's huge shifts, like for an adolescent girl, that's different. But most of the time it can adjust. I've just not seen a problem, I guess is what I'm saying.
Gotcha.
I haven't seen a problem.
Question about insulin. A couple of questions about insulin. One question came through was, how do we prevent weight gain associated with insulin use?
Well, so a lot of the weight gain of insulin use is hypoglycemia. So if you're not having hypoglycemia, you're not eating to treat that. And I don't know. You see, I have so many really lean, fit type 1s that I'm not so sure that I think that it's certainly not the same as in type 2s. This is me thinking. My partner says that I'm the only person he knows that actually gets like quiet because I actually am thinking. But I am thinking because I just have people in every weight category with type 1. So I have morbidly, obese people whose body mass indexes are greater than 40 or 50. I mean, really heavy people with type 1. And I have patients who are, really lean with type 1. I've seen everything. So it's different with type 2, but insulin is a weight, well, it's a hormone that makes you use glucose the way you're supposed to. So if you're matching your insulin requirements to glucose uptake in a balance, you shouldn't really be hyperinsulinized. And so it shouldn't really cause weight gain. And the data about the effect of insulin on the brain and hunger is complicated, and mostly in type 2s. And type 2s have an issue with GLP1, which is another hormone that has to do with satiety. So, but your insulin levels are always going to be higher than somebody without type 1 diabetes, right? Because you're giving insulin from the outside in, and somebody who doesn't have diabetes is making insulin from their pancreas, which goes into the portal circulation, which goes into the liver and breaks down. So your insulin levels, giving it from the outside, will always be higher. But I'm just not so sure that that's mandatory weight gain, is all I'm saying. You can certainly lose weight by having bad control, but that's not what we're talking about. And if you go from poor control to better control, you will gain weight because you were on a diet before and you didn't know it because you were leaking out all the sugar in your urine. I think it makes it somewhat harder to lose weight because of the risk, again, of going low. So we don't have data on weight change with systems that don't go low. So I've tracked the weight of all my patients on loop, on hyperclose loop, and all the systems. And I see weight loss or weight stability on all of my patients. And the ones who were overweight before don't lose, they wish that it magically made them lose weight. It doesn't. And I do see weight gain if they get their A1C's a whole lot better. But I kind of see what you'd expect from people as though they didn't have diabetes. So I was worried in the beginning that I'd see a lot of weight gain with these systems, but I don't. But I don't see massive increases in insulin dosing either. So I don't know. Anyway, I guess I'm not answering that question correctly. But all I know is I don't have a feeling that these systems, independent of improving glycemia, cause weight gain in the majority of my patients, which is not to say that they couldn't. But getting older causes weight gain. Being hypothyroid causes weight gain. I mean, there's a whole bunch of things that can cause weight gain. Sitting at home for COVID can cause weight gain. I mean, the thing is you're not immune for any other reason for weight gain. And you can lose weight with type 1 diabetes. So I don't know. I'm just telling you my own gut feeling about this and these systems. Other systems that cause hypos, they cause weight gain. But in my experience,
if you look at insulins, are you doing much with Fiasp or Lyumjev?
only it's based on what my patients want. I haven't seen a huge benefit, and most of my patients who've used it feel that it doesn't work for 3 days in their pumps. So they feel like they don't get the maximal benefit for the whole 3 days, so that they don't like it as much. But some people really like it. It's up to my patients. Whatever they want, they get,
Yeah, I tried it. Fiasp didn't hold in terms of control. Lyumjev, it just hurt. It just hurt. Every
Really?
ball is hurt. And after a while, I thought it's damaging skin. This is not smart.
No, pain is a bad sign. Nothing personal. But that's what I mean. Anybody gets, I'm just not that impressed. I'm really, the basic old rapid acting insulin seemed to me to work just fine.
Yeah.
But, and if we ever get a better, more rapid acting insulin, great, but I don't see it yet.
Okay. Let's talk about exercise. Glenn had asked you to tell your marathon story. Why don't you just talk to us about loop and exercise, and even extreme exercise, or anything, any wisdom you'd like to share?
Do we have 4 or 5 hours?
Sure.
Well, I don't. I have to have dinner at some point, but this is the deal. So the story about the marathon was a patient of mine who was on loop and did a marathon at Omnipod loop, and her Riley link stopped communicating with the pod. And that therefore meant that the pod defaulted back to her basal rates that were set for not running a marathon that were set for life conditions. And that basal rate was a killer, right? Because it was so high because it wasn't meant for all this activity that, she could barely drink enough carbs to keep up. But she knew if she just pulled the pot off, that then she'd become really hyperglycemic and not be able to finish. So she had a really hard marathon because the loop system, when it turned off, just didn't work. So for the next marathon, we gave her a basal rate system that was meant for running a marathon, so that if the loop failed, if the Rayleigh link failed and it didn't communicate, then she would default to the basal settings that were much lower that she could run a marathon with. And so she runs her next marathon, and sure enough, the system doesn't work and she's left on just the pot alone. But because now the basal was the right basal, she was fine. So it really requires, I think, if you're going to do something like run a race where you can't have a communication failure, to have the default settings, the right settings for that circumstance, because otherwise the default is for you wandering around and having, not running a marathon. So it really worked well to do that. But exercise is the toughest thing because it affects everyone differently, and it depends on the intensity of the exercise, the duration of the exercise, the type of the exercise, and the time of day of the exercise. And there's a training effect, so that when you first start working out, your glucose metabolism is different than once you've become trained. And so you're basically dealing with a system, your own body, that has so many variables in terms of responding to exercise. And you're trying to take an external system and make it react. And the whole notion of this has to do with insulin on board, because you have to reduce the insulin on board so that it's not going to push too much glucose into muscle and make you hypoglycemic. But you've got to have some insulin on board so you don't get hyperglycemic. And I think a lot about exercise is about doing an advanced reduction in basal if it's going to be aerobic, and then giving some basal while you're exercising, but then turning it back on before the end of exercise so you don't get that hyperglycemic post-exercise surge. Because basically at some point you need to go back to whatever it was that was going on before. And the reason exercise is so tricky is because when you're sitting here like this, insulin is pushing glucose into your cells and there's some sort of homeostasis. But as soon as you start exercising, there are the GLUT4 transporters, which basically means you start pushing glucose into cells without insulin. So there's non-insulin mediated glucose uptake and there's insulin mediated glucose uptake. So you've got to figure out how much is your cell going to uptake without insulin and how much is going to be an insulin effect. And that's why it's so hard to balance. And then if you're going to do resistance training or weight training, your sugars may not only not go down, they may go up. So if you do resistance training before you do aerobic exercise, it may really help you, because then you get the insulin resistance from the catecholamines, from the adrenaline first, and then you can do aerobic next. But then time of day really matters. So my favorite time for anybody to exercise is the time of day I personally hate exercising, which is first thing in the morning, because that's when you're resistant and that's when your hormones are helping you not go low. So that's when your cortisol and growth hormone are out. So that's when you're supposed to be chasing around. The worst time to exercise is just before dinner, because you're the longest away from a meal, from lunch. And so you don't have much carbohydrate on board, and your body's the most sensitive to insulin because your cortisol levels are lowest. So it's really hard to do it right. And after dinner is often good, because that way you can exercise down dinner if it was, for whatever reason, not quite right in terms of carb counting. But the problem with that, or any kind of exercise, is going low at night. So the system has to figure out not to make you low at night. The good thing about loop is I think it generally figures out how to not have you be low at night. But it's all about the balancing of all those factors. And yet my athletes can do anything, but it's what does your body need and how does it respond? But the concept of insulin on board. So this is not a loop problem, but I'll tell you my non-loop problem. So in the beginning with Control IQ, in Control IQ, there's a mode which is called exercise. And in exercise mode, it increases your target to 160. So it basically, instead of being 140, it's 160. So it gives you less insulin, but it still gives you these little auto boluses when you go high. So this particular patient of mine is somebody who's done lots of marathons and triathlons and trail races and whatever the heck else. And so she knows her body and she knows how to do exercise. And so what she does is she consumes carbs so that she gets her sugar up to 200 and then she goes running. She goes mountain running. And she did that, but she didn't know that the system, as she's starting to go running, gives her a bolus because it says, oh, well, I'm supposed to give you an auto bolus, but it doesn't really show you that it just gave you a bolus. And so she knew her body and she knew in the absence of giving insulin for the carbs she just ate that she'd be fine. But of course she isn't fine and she develops severe hypoglycemia while she's running and she eats all of her carbs and her sugar is still going like this. And fortunately, her husband is involved in search and rescue. She was in the mountains and they had to come in and rescue her. But it was all because the system gave her a bolus for a high that she knew was what she needed to get ready for exercise. So one of my problems with out of the store-bought systems is they can do stuff and you don't even know they're doing stuff and then you can go low. So, she and I have since worked it out. We have a whole regimen, she's fine. But, you've got to know if you're getting insulin before you exercise, because if you have too much insulin on board, that's what does it. So all I'm pointing out is that's what this is. And that bolus that the system gave her, she didn't know it was going to do it. She was we were both new to this. So every time I put a person on the Control IQ system, I say, you may just have to go back to the manual mode because this thing can give you insulin and you're not really aware of it and you'll go too low. So that's a weakness. You got to know the weaknesses to systems.
Do you have any more elite athletes who run with two Raleigh links so that there's no loss of connectivity, so they don't run out of a connection while they're in the middle of whatever they're doing?
I have not, because oddly, many of my athletes go back to simpler rather than more complicated. But so some of them have, someone calling you for dinner?
Oh.
So I haven't had anybody do two Riley links. I didn't even think of it, but I guess you could.
Several of us keep a second one high up on a headboard at nighttime, so that if we roll over and there's some loss of connectivity, that seems to keep absolute connectivity the whole time, and it works very well. It's just one of our little hacks.
That's adorable. I wish things were simpler. I wish there didn't have to be two Riley links, but okay.
Yeah. Well, I mean, you just set it up and it automatically will switch when one is not reading. It'll pull from the other. Oh, what a sweetie.
Wait, I gotta let her out.
Okay.
Dinner seems to be happening. Take it, girl. Here you go. But I like the idea.
What's her name?
Her name is Kit.
Oh,
She has some horrible, bizarre, infiltrating lipoma that only somebody like me would have ever diagnosed, because this dog limped and no vet on the planet could figure out why the dog limped. And finally, some really smart vets said, oh, I think it's scar tissue. If you really wanted to know, because nothing showed it. And I went and got a doggy MRI. I think most humans would never get a $2,000 MRI for their dog, but I love this dog and she's only 6 years old. But then I found she has this really bizarre tumor. And, there's this thing and the radiation and, oh my God, things we do. And I'm not one of those people, like I do put dogs down, but this one's just too cute.
totally understand. There's several of us whose cats or dogs walk by, so we understand. I'm going to shift here because of something that we have an interest in and we haven't fully understood what to do with it. But we all believe it's really important to have a Diabuddy network, a network of people who, and I don't know the parameters, but manage diabetes in a similar way, have similar or better knowledge on the technology, and are available to support a spouse, a partner, whoever. And I don't know if you have seen that in your practice or whether you recommend that just as a support network. We've been trying to figure that out, and we started a Diabuddy group and we fell into it. We don't know what we did that made it work. We think there's proximity because if I need someone to go to my house and I'm at the hospital, someone's nearby enough. We have each other's access to Night Scouts so we can see what's being managed. And then we started talking about how do we even help into the lesser advantaged communities as a more of a mentorship. So I know I'm throwing things at you, but I think we have a lot of knowledge that can be shared. And we're trying to figure out the best way to do that to support each other. We do that in the larger sense on SoCal Loopers or a Looped group or any of these Facebook groups, or when you can meet in person, the support groups. But particularly for the technology, it's really nice to have somebody who knows what you're doing other than your doctor. And how do you train your spouse? How do you, the question came up, how do you educate the endos and the CDEs to better understand what we're doing? So I've just thrown a lot of things at you and I'm so sorry, but that's all in my head.
Well, this is the deal. So my personal belief is that, so I've always believed in mentorship in general in life. And mentorship is not exactly what you're talking about, but it's close. And it means having somebody who is there and has your back. And I really felt that we needed to create a program in the world so that people graduating from pediatric care with type 1 could connect to adult care and not get lost. And a lot of our type 1, even people who were in really good pediatric care, get lost. And we've done programs with that, and having an ambassador or somebody that helps them get from point A to point B works. But all of that connects to the healthcare system. So what I've always thought is that everybody at the age of 17 or something needs to get a person that's their person, that then holds their hand through all of the transitions that happen in life as you go from 18 to 30 or whatever, however long it is to get healthcare. And that when you, as the patient, feel like you can't possibly figure it out, that that person can help you. So I've always felt there needs to be a support person that was not medical, that helped people transition. And so the notion of having a support person, I think, is huge, but I think it's incredibly variable, so that I have a lot of people who don't want their spouses involved. They just don't. And I always want the spouse to know how to give glucagon, which has actually become easier since we have easier forms of glucagon. But I have so many patients who I think that they feel that if it's somebody too close to them, that then it wrecks the relationship, because then the relationship becomes about diabetes. So that for me, and what you're saying is it would have to be somebody, for a lot of my patients, that wasn't their primary partner, because that makes them, it's sort of like you don't want to come home from work and both be in the same profession, because then you only talk about that profession. So you'd have to have a way that people just choose who that person is. And I'm sure that's what you want. But I think it's a really good idea to have one other person who knows about this. My person of all is, I have one son and he's 29 and should be good for something, right? And, I send him all of these stupid things. And, this is what, my medical needs are, even to the point of, because I've just watched my mother die and she was demented in a home, well, my right great toenail always splits. So be sure they don't put my socks on and pull that toenail. But, the stupidest things that only I know about myself, that I want somebody else to know about me if I were, not capable. And so I feel like it's incredibly helpful to have a steadying person, and a helpful person. A person doesn't have to have diabetes. In some ways, it may be better if they didn't, but it doesn't matter. That has to be the person that is identified by the individual. I want that person. And, I really love patient advocates. So I've had, patients come to see me with patient advocates, and I think they're spectacular because it's easier to talk to the advocate in the sense that the advocate isn't inputting information in a personal way. So to me, I think it's a great idea as long as people, choose it, but it also is a tremendous responsibility. So when my son went off to college, I thought I was going to be bored and lonely. So I decided I would do the Big Brother, Big Sister program, which is sort of what this is like. And I got a little sister, and she was 8 years old, and she was absolutely adorable. And I thought, this is the greatest thing ever. And I spent every other weekend with her. But that was 10 years ago, and I couldn't undo it. So to this day, I still have to take care of Skylar. And she's now a senior in high school. She was in second grade. But all these years later, I have to be there for Skylar. And you know what? I adore this young woman, but it's been a lot of work. And I'm telling you, I didn't know what I was getting into, but it has to be a committed person. This isn't going to be something that just goes away. And the worst thing I would think would be to be rejected by your diabuddy, like, oh, you're too much of a pain in the ass, or whoops, I'm not interested anymore. So there's this commitment component to this that is, it's a serious thing to be the support person for another person. And I don't take it lightly. And that's why I don't leave Los Angeles, is that I feel like, even though I have had many a better job offer than the situation I have at SC, I can't leave LA because I can't leave my patients, because I feel like I've made a lifelong commitment to them. And, I just think that you have to think these things through. And people, they can't get too busy and then say, I can't be there for you. I mean, you know what I mean? You have to figure out how to define the responsibilities of this. And we do get busy, and we change, and people have babies and lives and things, and husbands get sick, and all this stuff happens. So that's just why maybe there needs to be more than one person. I don't quite know how to define it, but I love the concept.
I'll throw out an idea. What if, yes, a person or one or two people who are kind of your backups, but what if there were an ancillary service through retired nurses? And is there a retired nursing association, or even nursing students? Is there a course that would then maybe they start to commit to choosing someone to be kind of a support in that? Because as I deal with people as they age, it becomes more and more of an issue. Even if they have a spouse, the spouse can die or get dementia, and that support goes away, or kids move away.
But I think that that age, that people getting older is really hard. I mean, I have demented patients who, call me 10 times a day. I mean, you can't extinguish it because they don't know what to, they get all confused. It's really tough. But I'm just pointing out that it all seems fine. And I really like it, but I really feel like there's things one would have to think through. But I like the idea of having some backup thing. But that I wanted to create a suicide hotline that existed independent of an institution, again, that people could call and say, I'm having these issues. And you guys are sort of like that. I mean, you for each other through Loop are your own hotline, but other people don't have that. But I want, because I think type 1 diabetes is so unique of all ailments, because it's so dependent on what you do And the line between living and dying, I don't mean to be scary, is pretty fine. I mean, if you completely blow it and don't give insulin for 3 days, you're in serious trouble. This isn't something you can just say, I'm done with for the weekend. It doesn't work that way. And a lot of other diseases, if you forget to take, X medicine for 2 days, your blood pressure may go up, but you're unlikely to have a bad outcome. This is serious. And that's why I want hotlines and support and connections that don't exist. I wanted to make, I wish we could make it something that was enduring, but the more you can do, the better. I'm all into it, but I would start, to be honest, trying to help people who are transitioning from, pediatric to adult care, because people get so lost. I mean, they could use just even knowing that people are out there, but I don't even know how to get the word out. Anyway, that's up to you all. I can tell you I wholly support the idea, but you got to think it through very carefully.
We're talking about calling them blood brothers and blood sisters, hoping that little brothers and little sisters wouldn't mind us borrowing that part of the name.
Yeah, but that sounds like vampires. I don't want to have a vampire whole system. Oh, for God's sakes. It's interstitial fluid now anyway. Do not use blood.
Okay, we will not use blood.
But it is like Big Sisters, Big Brothers, or Suicide Hotline. It's about interconnecting people so that there's support that is, true support. And the other thing, though, is you do get crazy people. I mean, I'm not joking. So you got to, there has to be, everything has to be curated and monitored in a way, because if somebody gives somebody bad advice, again, the downside with diabetes is the bad advice can cause a terrible problem. And you got to know, but by the way, I don't think most patients get the right advice. So any sane advice is better in many cases than certain medical professionals. So just pointing this out, you're better than nothing, but just make sure it's sane.
I have to say wow to what you just said, and I agree with you. And you have to be vigilant. You have to kind of fact check in your brain, does this make sense? Because if it comes from a medical professional, there's a tendency to say that's correct, which may or may not be true.
No, you got to doubt you have to tell your truth, and your truth is your truth. And we medical professionals, I know a lot about a lot of things, but I don't know what your reality is.
Mm-hmm.
So I think that there's got to be a balance.
Yeah. I one more question, I'll come back to you on just more medicines, SGLT2s and those extra things that are barely approved or maybe just approved for type 1s. For people in the looping community, are they less significant because we are doing pretty well with control?
Well, it's things, it just depends. So using a GLP1 receptor agonist, which can be a weight loss drug in non-diabetic people, is actually a weight loss drug in people with type 1 diabetes. And so maybe using a GLP1 receptor agonist for weight loss and to some degree postprandial hyperglycemic reduction it would work in somebody on loop. I know it does. So I've used the GLP1 receptor agonist to help with weight loss. In anybody on any system, it helps because, again, it's about weight loss, not the insulin. Then SGLT2 inhibitors, which I haven't been using as much with the pandemic because I've already had people go into DKA on them, but they help reduce postprandial glucose levels and also help reduce weight and blood pressure. And they're really, really, really good at slowing progression of kidney disease. And they're also helpful for your heart. So why shouldn't type 1s who need them use them? But the risk is DKA. But certainly it's an agent that will never get FDA approved because of the DKA risk. But I think of loopers as the most responsible. And therefore, I think they could use an SGLT2 inhibitor safely. And if I had, kidney damage, I think it's a great drug to help reduce, renal issues. So, there's a time and a place for all of this, and it's not necessarily a glycemic related response. But if somebody has cardiovascular disease, GLP1 receptor agonists and SGLT2 inhibitors in type 2s reduce the risk of dying by 36%. That's huge. And so why shouldn't that benefit be there for type 1s? They're never going to study it. But because the mechanism seems to be independent of insulin, but it has to do with direct effects on the heart and the vasculature, I don't know. So again, it's all about figuring out your individual needs and being creative as to what might benefit you. And it's not just glucose.
Got it. Okay. Well, I read something today that I thought was kind of interesting, and it said a New Yorker said, "I'm having to do with COVID and all the craziness in the world." He said, "I'm so tired of everything. Is it going to be over? I want it to be over." And I sat there and I looked at that quote and thought, well, people with diabetes have a very different approach to things because it isn't over, and we have to learn to be resilient and change and adapt. People that don't have diabetes, I guess we're better prepared, is what I'm trying to say. We're more used to saying we'll deal with it.
Yes, but I wouldn't. So there's several things. So first of all, the people who are doing best with all this are the ones who've realized that humans are amazingly adaptable. And if you can adapt to what we're going through, then you're going to get through it much better than if you fight it. That's key psychologically. But I've seen more psychological ailments starting in the past month or so than I have in years. And I've had, to refer a number of people to the suicide hotline. I've had all sorts of stuff going on that people are really, this is exacerbating underlying mental illness. So I think that people with diabetes have a coping skill, but that doesn't make them immune from other mental health conditions. And there are a lot of those out there right now. So I'm actually particularly worried that things are going to get worse. And everyone of, us needs to just be aware that this is a stressful time and it's going to be a hard, long winter. So just reach out for support and connect with each other. And it's okay if you're depressed, ask your doctor for help and talk to a therapist and get an antidepressant. But I've seen actually increasing amounts of mental health concerns lately.
Yeah, we see that too. You hear that, everybody. Reach out and support our community. If you're having a good day, reach out to someone who may not be. So that makes perfect sense to us. Thank you. I will let you go feed your dog and feed yourself dinner. And thank you for taking time on Sunday. We had quite a few people over on Facebook, and I will have this edited and up tomorrow. I really appreciate your time.
Well, thank you guys. You guys are great. You all do such a wonderful job. I'm so impressed by your community. I can't stand it. It's like, wow, it's pretty cool. So keep up doing the good job that you're all doing. Okay.
Thanks so very much.
All right.
Bye-bye.
Bye, guys.